Hi, my name is Dr. Debbie Stevens, and I am a CLL specialist at the University of North Carolina in Chapel Hill. And I am very pleased to be joined today by my friend and colleague, Dr. Ryan Jacobs from the Levine Cancer Institute in Charlotte, North Carolina. Thanks for joining.
Thanks for having me.
Today, we're here to talk about one of the abstracts that you presented at the recent American Society of Hematology meeting. And the title of this research is Best Practices to Overcoming Challenges in Initiating Venetoclax for Patients with Chronic Lymphocytic Leukemia, and their results from a United States community-based healthcare practitioner survey. So thanks for being here to talk about your research. One of the big premises of this is, in general, once a patient with CLL needs treatment, there are generally two different strategies for the first line of treatment. That can either be indefinite therapy or basically one with no end date. And this most classically involves Bruton tyrosine kinase inhibitors or BTK inhibitors like ibrutinib, acalabrutinib, or zanubrutinib. Or the alternate strategy is to do a time limited, meaning at the beginning of therapy, we know exactly when we plan to stop the treatment. And this usually involves the drug Venetoclax. So Dr. Jacobs, can you describe the difference between what is involved when a patient starts either of these two different treatment strategies?
Sure, and thanks for that introduction, Dr. Stevens. I um, I think it's maybe a little bit counterintuitive, when patients think about the treatment options and what ultimately is more commonly prescribed. So for the BTK inhibitors, like you described, ibrutinib, acalabrutinib, zanubrutinib, one might think, well, why would I necessarily want to opt for that approach when there is a time-defined option? But in fact, and part of what motivated this project, the the reality is the indefinite approach is much more commonly utilized in clinical practice, and the reason being is it's very easy to administer as a single oral agent and requires very little monitoring in most cases. So patients come and they have a problem from their CLL and they need treatment, so they get started on a pill as a single agent and generally get told, we'll see you in a month, and probably before too long, the appointments are spread out even further than that. So certainly the indefinite nature of it is a downside, but the ease of administration and follow-up is probably one of the leading factors for why it's more commonly utilized, along with its great efficacy. The time-defined approach, which again sounds very appealing to just, for example, in the first line setting, get treatment for 1 year and stop, but it combines both an oral treatment that's venetoclax based. Venetoclax is our only BCL2 inhibitor that's FDA approved at this time. So really, when you're talking about targeted therapies that are time defined, they're all going to involve venetoclax in some way. But it's not just venetoclax alone, which is a pill. It is also combined with a monoclonal antibody, which is intravenous. And more often than not, these days we're using a drug called obinutuzumab, which is sort of a better version of an older drug called rituximab. And so right off the bat, some patients are maybe not too excited about spending time in the infusion center and getting the antibody treatments. But beyond that, there is the need for ramping up venetoclax. So as opposed to the BTK inhibitors, which you start at the full dose and don't adjust it unless there's a problem, Venetoclax, it's a 5-week ramp up process, and when the label is followed in terms of um, doing the appropriate monitoring throughout the ramp up, it takes 5 weeks, and there's a lot of lab checks mixed in there, especially towards the beginning. So when you add in the IV lead in with weekly infusions for the first 3 weeks, and in fact, there's 2 infusions on the first 2 days, so day 1 and 2, and then again on day 8, then again on day 15, and then you add the 5-week ramp up of the venetoclax on top of it. It makes for a busy 8 weeks. So how I explain it to patients is, yes, it's a lot busier than the first 2 months with the BTK inhibitor, but you're putting your work in early for the payoff that comes with multiple years um, off treatment. So the data indicates that the majority of patients will have a multi-year, what we call treatment holiday, and stay in remission. So that's a really brief breakdown of the two approaches.
Yeah, thank you for that. And so moving back into this particular research project, can you tell us what questions you were trying to answer and what was your approach to answering them?
When you look at the objective data from pharmacies, what is being prescribed to CLL patients, whether it's first line or relapsed, venetoclax-based therapies has been around 15%, give or take, and that really hasn't changed much over the past several years. BTK-based treatments that are indefinite, the acalabrutinib, zanubrutinib, or historically ibrutinib, those comprise closer to 50, 60% of prescriptions going out for CLL patients. So the aim of our project was to try to, at least from the healthcare provider standpoint, get at, is there any barriers to utilizing the time-defined approach, which we feel is a really great option for many CLL patients to reduce both long-term accumulation of toxicities when you take a drug year after year, as opposed to just 1 year and stop, as well as you know um, uh, being able to reduce the financial toxicity, to only have 1 year of treatment versus multiple years. So we were interested in hearing from healthcare providers, specifically, oncologists treating CLL patients that have had some experience using venetoclax in terms of what's going on in their practice.
That's great. And how did you reach out to these providers, or how did you collect your providers who are answering questions for you?
So we engaged Aptitude Health, and they are a network that do a lot of different things in terms of education and consulting with physicians. So we together, the authors put together a questionnaire, and then Aptitude Health leveraged its network of advisors to send out the questionnaires, and a percentage of those ultimately chose to participate in the questionnaire, and we were able to put together their answers, and look at what they had to say about how they have facilitated using venetoclax in their practices, what are some barriers, and just how they are discussing first line treatment in particular with CLL patients who haven't seen either venetoclax or covalent BTK inhibitors.
Sounds like a great way to reach a broad group of providers.
Mm-hmm.
So what were the major findings of your research project?
And it was a broad group. We eventually got about 139 oncologists to participate, and there was a distribution between urban, suburban, and rural settings. And to qualify, the oncologist just had to have seen at least 10 CLL patients in the past year and had to have used venetoclax at least once. So the just some interesting observations off the bat. Of those that were engaged, just right off the bat, 23% said that they did not even discuss fixed duration therapy as part of first line treatment. And and personally, that didn't surprise me. I do think that many times this option is not discussed with patients. We have to take off our CLL specialist hat and put ourselves in the shoes of a general oncologist that has to treat a lot of other cancers and often benign hematology, and it's tough to keep up with everything, and particularly with CLL when they maybe only have a handful of new treatment starts a year, and just with the extra knowledge base that's necessary, and historically BTK inhibitors have been around longer, in particular ibrutinib. Um, it's not surprising that oftentimes the fixed duration therapy with venetoclax based treatment is not even discussed. But of those that discuss the the both treatment options or report that they do, 65% ultimately said that what they end up going with is indefinite treatment with BTK inhibition. So it seemed like there was an honest reflection of what the data shows, that either in terms of contributing to these low rates of fixed duration therapy with venetoclax, it's either treatment's not being discussed, or when discussed, ultimately more often than not, um, either through the patient choice, or through a collaboration with the patient and the healthcare provider. They're just choosing to go with indefinite BTK inhibition. In terms of some things that these providers had found success in implementing in their practice to facilitate um, uh, um, using fixed duration therapy, having sort of a protocol and an algorithm that is saved and written up for the TLS monitoring, management, scheduling of labs. That was what was the most common intervention, and sort of working our way down, facilitating patient visits in relation to lab tests, and having sort of a protocol for that, training of staff so the perhaps lab visits don't require necessarily physician review for monitoring TLS. They can sort of be pre-screened by staff, and the physician can be contacted if concerned. Being able to do stat lab results and getting TLS lab results back within a few hours versus sending them out, that was a key component as well. And then there were some other components like creating patient calendars that was thrown in, and having support for transportation for patients that maybe have trouble getting to and from the cancer center. In terms of some things that they identified as challenges and maybe contributing to the lower uptake of fixed duration therapy, concern about TLS actually registered as the highest. So they rated sort of 1 to 5 different categories of concern, and concerns about TLS came in the highest. And I think this is where education could be helpful, because when you look at the trials, the prospective trials, as you know, when you follow the ramp up, there's essentially zero clinically significant TLS. I mean, I think the actual number is around 1 or 2%. So it's incredibly uncommon, and probably the ramp up is overkill, honestly, for most patients. And we've looked at that in our system and published on that probably most patients don't need this extensive of a ramp up. So I think maybe with education we could help in lowering those concerns about TLS, but sort of working way down, patient logistics. I hear about this a lot. Patients just don't want to come to and from the cancer center. Clinics that can't get that lab turnaround with TLS labs quick enough, and just the sort of arduous nature of doing that post dose monitoring, particularly the 6 to 8 hour post dose lab check. Not as much concern with the 24-hour lab check. And one that I think didn't register as high, but what I hear about from patients is just wanting to avoid the infusion center. So particularly obinutuzumab and its potential infusion reaction. So that was I would say the highlights of what the survey was able to reveal.
Yeah, so that's all really interesting. It sounds like there's still quite a bit of hesitancy for doctors using time-limited therapies just because there's a lot of logistical details that have to be in place. And especially if you're not seeing a lot of patients that have CLL, maybe putting all of those, pieces into place, they may not have the time to do that amongst all the other patients that they're seeing. Because it sounds like, doing some protocols and, study calendars for patients, a lot of things that were really helpful to those who are using it. And so really it did show a good analysis of how centers have been able to successfully do the time-limited therapies. How do you think your research can benefit patients with CLL?
I think if more oncologists are seeing some of these listed interventions that have been found to be beneficial in initiating time-defined therapy with venetoclax and implementing those, then hopefully that could lead to getting over sort of that learning curve, if you will, in a lot of practices of using Ven. And once you do it a few times, you're more likely to feel comfortable, both you and your clinic staff and lab, et cetera. So hopefully comfort level can be increased with time-defined therapy. I think it's another bit of evidence to support what I know the CLL Society is always championing. If you can get access to a specialist prior to starting treatment to have this discussion. And I've always found consulting physicians to be very open to collaborating, and maybe even if they're not comfortable in starting the Ven locally, I can start the Ven in obinutuzumab at my site, and eventually send them back out to their local oncologist when the ramp up is finished, and patients just need to come in, once a month or so for check-ins. So I'm hoping, maybe just through those couple of potential benefits that could lead to more implementation of time-defined therapy. Because really, regardless of the venue, when I talk to oncologists, whether they're specialists or not, the enthusiasm for time-defined therapy is high. We just have to get it into practice more.
Yeah, this is great. And your research showed a lot of ways that centers are doing this and doing it well. And so I think the centers that don't have a protocol set up can be reassured that they don't have to, I guess, reinvent the wheel per se, that there's lots of centers that are doing it, and maybe just adopting a protocol that's being used somewhere else. And I think it's important, not because, not all patients need time-limited therapy, or maybe that's not the best option, but at least having time-limited therapy available as an option, I think is really important for patients. So, thank you so much for the research that you are doing, and thank you for being here today. And as always, the support that you provide to the CLL Society and all your patients.
All right, thank you.